appearing. Now, this was at a point in time where it was a lot worse. Today, you're appearing much better.
Yeah.
So, basically, I'm going to show you on this model first here. You showed me your MRI. You showed me all this other stuff. Basically, what you're doing is this.
Yeah.
When we bend forward, we help to wedge that disc that's
Yeah.
leaking out further out.
Mm-hmm.
Okay? When we bend backwards, we do this.
Mm-hmm.
We reabsorb that.
Yeah.
So you're doing the McGill Big 3
Mm-hmm.
that helps strengthen the core and helps solidify, like, so that it's not so sloppy, like the joint's not sloppy and it's not moving too much. That's a great job. But you also need to help reabsorb that disc. Now, I tested you, just so you know, I tested you for some issues with the nerve and the sciatic nerve and stuff like that on both sides. You know that I did it on both sides. I even pulled down on it going this direction, this direction, and I tested all the different areas. Nothing popped up neurologically, so congratulations on that. You did have a little bit tighter hip flexors, and then when I kind of manipulated and worked around this area, like, yeah, I can feel it. So I do think it's a little bit more bulging to the left, giving a little bit more left side symptoms. That's why you bending over it to the left and me kind of doing this. What I'm trying to do is corkscrew it and kind of doing this to the left, this to the right, and like, hey, that's kind of bulging out a little bit to the left.
Yeah.
Nobody likes that.
Yeah.
In that case, that's pretty good, but I think a lot of the mobility is kind of protective. I do think the McGill Big 3 is going to be worth your while. I don't. I'll tell you my opinion on it later, but in terms of like what I think is necessary for you, but neurologically everything is sound. So we can take the nerves out of this case, at least at this point in time.
Yeah.
Now, one thing people will ask me, like, well, how the hell do I get that bulge back in? Am I going to get it back in? Statistically speaking, I'm going to say no. You're never going to get it 100% back in. 48% of all the disc compressions spontaneously reabsorb. Meaning 48% of people are going to have 100% reabsorption of that. Meaning 52% are not.
Yeah.
So you're like, well, that's actually still a pretty good number, considering that.
Yeah.
But the thing is, the biggest thing is the 52% only need 1 millimeter reabsorption or 2 or 3 just to feel no symptoms. So just because you, like, let's just say you bulge that out 4 millimeters and it subtracts by 1 and now you have a 3 millimeter bulge, you might have no pain ever in the rest of your life.
Yeah.
But you might have disc compression. So that's really my thought process on it. Is like, we can go out there and MRI 1 million people, and of those 1 million people, 998,000 will show up likely positive with some sort of disc compression. The question is, are they symptomatic or not?
Yeah, I've been reading a lot about like the image isn't like everything, and like different people could have like more severe and not have any pain, and then it's like,
I've seen things that are way worse on their MRI and having no symptoms. I've seen things that are way worse have way worse symptoms.
Yeah.
And I've seen things that were a little bit less than what you showed me and having more symptoms.
Yeah.
So, but that's why the ortho test and the neuro test with what me lifting the legs and doing all this stuff is important. So if we can do some of this McGill and this extension stuff that I just showed you, then maybe, just maybe, we can reabsorb it a little bit more. Or maybe, let's just say you're surfing, you have a nice wipeout, your back starts to hurt, and instead of going into McGill Big 3, you go into some sort of extension stuff and help reabsorb that compression very soon after.
Yeah.
And then that can help take your pain from a 6 to a 5 to a 3 to a 1, and you're like, hey, I'm actually not so bad.
Yeah.
Or you sit in the sitting position, which is a C-shaped position, which is this C shape. Because really what I'm saying is, like, at the end of the day, a lot of the times people have this nice little lumbar curve. We tend to flatten that curve out and or reverse it when we sit, which is like how you wedge that disc backward.
Sure.
And that's why sitting hurts you.
Yeah.
Well, that's why bending forward and touching your toes hurt you. This is also one of the reasons why stretching your hamstrings are not good. And we'll talk about that in another time. But
yeah, that was the other thing I kind of learned through all this. Like, I have a back thing. Like, what am I gonna do? Like, bend over and touch your toes and hold it. And I was like, it's like the worst. I'm just like squishing it all.
That's actually the most common problem that people do that actually worsens their symptoms, which is baby step 3, which is stop pissing it off. So if I tell you hamstring stretching is good for you and you say, okay, great, and then like you go home and do hamstring stretches, and it pisses off your back,
Yeah.
and sends numbness and tingling into your toes.
Yeah.
Why would you continue doing that?
Yeah.
It's like, yes, I get it. Some people just follow instruction because
Mhm.
that's just what they do.
Yeah.
But like, use a little intuition. Like,
Yeah.
even if I tell you this exercise is the best thing for you,
Yeah.
if you go home and you're like, hey, this actually feels worse,
Mhm.
you stop.
Yeah.
You use your intuition
Yeah.
to do that. But basically, this is pretty fun to treat because you have a good broad background. You are not having anything neurologic,
Mhm.
and I'll just teach you a few other concepts, and it'll help stabilize your injury a lot faster.
Great.
So, yeah, you should be